This is Tokens. I'm Lee C. Camp. We talk a lot on our show about the intersection of ethics and politics. That is just how our morals and value systems are working to govern, or not, our communities, cities, and countries. And there's perhaps no stage on which this intersection is played out more than on the stage of healthcare. In 2020, we saw the healthcare system at its finest as scientists and frontline health workers worked selflessly and tirelessly to save lives, culminating in the production and distribution of the COVID vaccine with unprecedented speed. Yet alongside such impressive feats, we've continued to see the troubling ways in which disparities in both healthcare and health outcomes persist. And some of those disparities have a long history.
So, health inequity started with slavery.
That's Dr. Quincy Byrdsong, longtime public health professional and now a colleague of mine, as Vice Provost for Health Affairs at Lipscomb University here in Nashville.
What we're finding now is that these health inequities still exist, but they were hidden a little bit because there's a lot of conflation between race and socioeconomic status, race and education.
Dr. Byrdsong has spent a large portion of his professional career studying the ways in which variables like race, sex, and class correlate with or cause the gaps between those who are granted ample access to health care. Or even more troubling, he's done a lot of time studying cases in which some were used by the system of healthcare and healthcare research, such as the infamous case of the Tuskegee Syphilis trials.
There was a scientist that was involved in the study that said the Negro serves a better purpose in the laboratory than in the classroom. It's better for us to use them as guinea pigs than to have them be educated.
Today, a conversation about the ethical implications of healthcare as seen through the often troubling history of health inequity in the United States and the progress that is being made in bridging those gaps.
There are paths that you can take in spite of sort of the things that are going on with injustice.
All this coming right up. Dr. Quincy Byrdsong holds bachelor's and master's degrees in biology from Middle Tennessee State University, earned an EDD at Tennessee State University in Nashville, and currently Dr. Byrdsong is Vice Provost for Health Affairs at Lipscomb University in Nashville, Tennessee, which makes him one of my new colleagues. So
yes.
Welcome, Dr. Byrdsong.
Yes, no, thanks for having me.
It's great to have you. So you've been doing lots of work with regard to public health over the last number of years, right?
Yes.
So when you think about public health, and I know that you've thought a lot about kind of access and justice questions related to public health, what are some of the big concerns or big questions in holding together issues of justice and public health?
Yeah, that's a great question. And in order for me to answer that, I probably need to go back a little bit and give you a little bit of the history of sort of the health inequity.
Yeah.
And so health inequity started with slavery. The slaves did not have access to health care, at least in the traditional sense. So the only time a slave would be treated for anything is if the slave's health condition really hindered him or her from being able to do their work as a slave. So if their arm was broken or they had joint issues and it really hindered them from doing their work as slaves, then they would be taken to be seen by a physician and they would get sort of essentially patched up and then sent out to continue to do their work. So the thing about this, maintenance and getting checkups, the slaves never had any of that. So that sort of was the foundation for the health inequity. So there were really two times in history where these health inequities were really addressed. So the first time was Reconstruction right after the Civil War, right? So once the Emancipation Proclamation was ratified and the slaves were freed, there were a whole lot of programs that were now available for the former slaves. So there were clinics that were open for them, access to food, pantries, that kind of thing, access to property. And it was a really concentrated effort to make sure that the former slaves would now have access to, health benefits. The same thing happened with education. So this was the same time when the higher ed institutions were created, the Morehouse colleges, the Tuskegee institutes, to make sure that now the former slaves had access to education. So that was the first time. Well, the health inequities then sort of went back during Jim Crow. Health inequities, we saw health inequities again. And then the second time in history where these health inequities were addressed was during the 1960s with the civil rights bills. So now we have more access to healthcare again, more access to treatment, more access to facilities, because during the Civil Rights Bill, now it's considered unconstitutional to have separate facilities, white, colored. And so now the Civil Rights Bill eradicates that. Then that sort of evened the playing field a little bit as it related to health. Now, fast forward to, 2021. What we're finding now is that these health inequities now, they still exist, but they were hidden a little bit because there's a lot of conflation between race and socioeconomic status, race and education. Mm-hmm. So a lot of what is attributed to race probably should be attributed to socioeconomic status. A lot of things that are attributed to race probably should be attributed to education. But we're having a difficult time, Lee, unpacking those two things.
Right.
But under COVID-19, we were able to start unpackaging those. What we saw, particularly with sort of the incidence of COVID, you were twice as likely to get COVID if you were Black, 1.5 more likely to get COVID if you were of Latino origin. It's just like, hold a second, there may be something here. And then we come to, the vaccines. So in the vaccine trials, the Pfizer trial had, 8% Black participants in the trial. Moderna, similar. And so it's like, wow, we're getting ready to test this vaccine and then distribute it out to the general population when we've only tested on a very small portion of Black and Hispanic individuals. And so this vaccine that we're going to be taking, do we really know how it affects people of color if 80% of your participants were white? So this is what we've sort of run into. Now, what does this have to do with social justice? So let me tie that in. So with social justice historically, that phraseology, social justice, it really started during the Industrial Revolution, right? But it was really more, how do we make sure that the haves and the have-nots have the same access to things? Do they have the same opportunities to pursue the things that they want to in life and able to contribute to the world in the ways that they've been called and purposed to do? But the social justice in the Industrial Revolution was social justice within one race of people. It did not include women. It did not include people of color. So now when you talk about social justice in 2021, now we're talking about, how does everyone get opportunities?
Equal opportunity.
Equal opportunity. Now it's more about human rights, right? It's more about regardless of gender, regardless of race, regardless of socioeconomic status, regardless of physical ability. Now social justice is, how does everyone get access to those things? But if you think about some of our main social justice issues, it's, voting is a big one, education. And one of the biggest social justice issues happens to be healthcare, right? Because of the health inequities that I just brought out. So these things are very much related and they're intertwined. We feel like if we can address some of the social justice issues, we may be able to address some of the health inequity issues and vice versa.
Fascinating. That's a very helpful overview. So I know that one area that you've done a lot of research on is the infamous case of the Tuskegee Syphilis study. So could you give us just a brief overview of that case?
Sure.
And what happened in that episode?
So Lee, this is the perfect example of when health equity and social justice collided. Perfect example. So, during the late 1920s, syphilis was, it was ravaging, particularly the Deep South, particularly in Macon County, Alabama, which was where the highest prevalence of. We're talking about close to 40%.
Wow,
were syphilitic. So you just think of that visual, right, Lee?
Yeah.
Every 10 people in this county, 4 of them were syphilitic.
Wow.
So there were a lot of people that were concerned about that. And it was a health inequity because it was disproportionately affecting, you think of Macon County, Alabama during the 1920s and 30s. We're talking about 87% Black, right? So we're talking about a predominantly Black county.
And Macon is where Tuskegee is, right?
Tuskegee is one of the cities in Macon County, Alabama. Yeah. So it was a health inequity. And so everyone was like, yeah, we got to address this. So we had philanthropists, one in particular, Julian Rosenwald, who was a contemporary of Booker T. Washington, who had actually funded a lot of the early universities for Black people to attend. So he dove right into this. And so he funded a treatment program in Macon County, Alabama to treat the syphilitic individuals. A lot of money was put into this project.
And this is well before the use of penicillin.
Yes, penicillin had not even been discovered at this point. So we're talking about early 1930s. So now we're seeping into the Great Depression. The money dried up, even for a philanthropist like Julian Rosenwald, who was one of the founders of Sears and Roebuck. He's a very, very wealthy man, but even for him, the money started to dry up. So what the physicians in these treatment programs did, they convinced the Macon County treatment program patients that they are going to come in and continue the treatment program. But in actuality, what they were doing, they were following these individuals without treating them.
Which is, it's just sort of overwhelming to realize.
And they told him that, hey, we're going to continue to treat you all, And so the individual was like, wow, this is great.
So it's a promise of free health care to a group of people that generally wouldn't have good access to health care.
It was free health care. In some cases, it was free room and board because they would stay in the facility. And then, you're part of something really special. The federal government was funding this effort, but they were being lied to. So a very, very responsible situation of addressing the health inequity turned it up into a violation of social justice, because now they're lying to this group of people. These individuals think that they're being treated for syphilis, when in actuality, they're being followed untreated. They have no intention to treat these individuals. This went on for 40 years.
The fact that it went on for 40 years is another just mind-boggling reality about that case.
Yeah.
I was just reading a little bit about this. So the potential symptoms or outcomes of syphilis could be blindness, deafness, mental illness, heart disease, bone deterioration, collapse of central nervous system, and death, as well as infection of others if untreated, right? And I think I read that there were something like quite a few of the study group died. Was it about around 400 people that were involved, or what were the numbers of people that were involved in the study?
We had 300 subjects, more or less, 290 somewhere, and then there were 100 controls.
Okay.
Yeah, so it's 400 total.
Okay. And then there was some number that died directly from syphilis.
Yeah, so the number that was, the number that died or either was permanently disabled, we're talking about half of that experimental group, more than half.
And then I think I read also that they had at least 40 cases in which wives contracted syphilis, and then maybe 19 children who were born with congenital syphilis as well from this group. And then once penicillin became available as a very effective treatment, right, in the 1940s?
Right, about 1945-ish. Yeah.
And then they simply were not offered this either.
Yeah, so the study personnel went out of their way to make sure that they did not get penicillin. So a couple of things that they did to ensure that. So penicillin was given to the military. Anybody in the military that contracted syphilis would get penicillin. So they did not let anyone in this project enlist in the military. And also the draft commission was given a list of these individuals that none of them could even be drafted. So they went to great lengths to make sure that this population did not get treated with penicillin. And then also the study personnel, because the treatment programs started to revitalize in the 1950s because we had penicillin. So if ever the study staff saw any of these individuals trying to access these treatment programs, they would pull them out of line, or they would contact the physician and say, no, this individual is part of a special effort funded by the federal government. You can't give them penicillin. I mean, they took great lengths to make sure that these individuals did not get treated.
A widespread systemic issue, right? Not just one or two players here, but...
Yeah, they involved the physicians in Macon County. Many of those physicians were physicians of color. They involved a community health nurse as one of the main people that coordinated it, who they knew that these individuals would trust completely. She was also a graduate of Tuskegee. Wow. So they really, for lack of a better word, they really exploited her relationship to these individuals, to this community, to make sure that this, it essentially allowed it to go on for those 40
Was
years.
she also aware of what was really
She
happening?
She knew something was wrong. But you got to understand, this is a Black female that's under the supervision of,
Right.
people that are being funded by the government. She didn't have a lot of influence in terms of, getting it turned in the right direction. But when it was all said and done, she was one of the people that really was able to describe what was going on and what had been happening to these individuals over time. And, and our very own Fred Gray, he was the attorney that ended up representing the families in this study.
Yeah. And then that case, they won a $10 million verdict, I think,
$10 million
against the federal government, and an
lawsuit
apology.
was $1 billion, but they settled for 10.
And then there was an apology, I think, from Bill Clinton.
Apology from Bill Clinton.
Yeah, to the participants. So my understanding is that even the presumed scientific agenda of the Tuskegee Syphilis study turned out not to be sound in the first place. The argument was, as I understand it, that they were seeking to study the consequences of untreated syphilis, and yet the way it was constructed turned out not to be a legitimate scientific study. Even if it had been ethical, the scientific undergirding of the study turned out to be insufficiently considered.
Yeah, so the history of this particular study in Macon County, Alabama, it was based on a previous study that had been done in Oslo, Norway, the study of untreated syphilis, but these were in European males. These were all white males. The scientific rationale behind the Oslo study was that if you don't do anything at all to people with syphilis, only a small percentage of them develop any symptoms. So that was sort of the background. So they said, hey, let's do a study where we actually look at syphilis untreated and see if there's any difference between the people we treat with syphilis, with these, arsenic and mercury, and the people that we don't treat at all. And so that study was going to be duplicated in Black males. So why did it need to be duplicated? Well, in the United States, there's a stigma around sexually transmitted diseases. And the federal government did not want to do studies on sexually transmitted diseases because then you had to talk about things like sex, sexual contact, sexual intercourse, who is having sex with whom, and all this kind of stuff. The scientific community sort of shied away from it, but the Public Health Service said, no, the responsible thing is for us to actually study this, because sexually transmitted diseases, we need to know more about them in order to be able to have a responsible, approach to it. So, number one, the rationale was we need to study syphilis because it's an epidemic, right? Number two, we need to see what happens when it's untreated, and we need to compare it because the original study in Oslo had all white males. We need to have a racial comparator. The rationale was if you do nothing, they might not develop symptoms anyway. The third thing, why the racial comparator was important? Well, it turned out that Black people with syphilis had cardiac events, whereas the white people with syphilis had neurological events. So there may be some difference in how the natural progression of syphilis manifests itself in a white male versus a Black male. And so then you think about males. Well, male sexual organs are external. So when they develop a lesion, you can see it easier than in a female. And so you would be able to tell when a male got syphilis sooner than you would be able to tell. So the time of onset would be a lot easier to tell in a male. So this was sort of the scientific background. So this makes sense. This appears to have some sort of scientific merit. And that was why the federal government funded it initially, because of those things that I mentioned.
Is it also true that the Oslo study was retrospective in the sense that it was looking back at people reporting what had happened? They weren't necessarily following people in a study along the way?
Yeah, so it was retrospective in the sense only half of the people were being treated for syphilis. So it was at the physician discretion. So what they did was retrospectively, they looked at the outcomes of the people by physician discretion, chose not to treat their syphilitic patients. So it wasn't like it was a prospective, hey, we're going to have this arm of people that don't get it.
And we're not letting them get treatment.
And we're denying it from this group.
Right.
It was more, we need to look back at the people that didn't get treatment and compare them to the people that did.
Right.
It was more retrospective, in nature.
And you're not having to deal with the issue of informed consent at all in that
Right, because you're looking at
retrospective
everything, after the
Right.
fact. The syphilis study in Mankind Abounds was different in that you were prospectively and you were deliberately denying them treatment.
and
so you
deliberately
could study it.
deceiving and
And
deliberately
deliberately
deceiving them. Yeah.
so you could see what would happen if it went untreated, and so you could see the progression. But like you said, Lee, they were told that they were continuing to be treated. And so when they would get things like lumbar punctures, which are very, very uncomfortable, they were like, oh, no, this is part of your, and here's what they called it it's a stretch to call this a consent form, but that's what they called it. But anyway, the form talked about special treatment.
A spinal tap gets to be called special treatment.
Special treatment.
Oh, my goodness.
This is your last chance for free special treatment. I can actually, I can email you the form. All caps. This is your last chance for this special free treatment.
Duplicity and deception, one on top of the other.
So that was sort of the scientific rationale behind it. It wasn't the greatest scientific rationale, but it was scientific initially. And had we never developed a treatment for syphilis, then probably following it untreated might have made sense. But even then, they needed to be told the truth. There was a scientist that was involved in the study that said, the Negro serves a better purpose in the laboratory than in the classroom. Because, there was a big push during this time of Black people going to college and improving their situation through higher ed. And this scientist said, well, no, we don't need to waste higher ed resources on them. They serve us better in a laboratory. It's better for us to use them as guinea pigs than to have them be educated. So this is a scientist saying this.
I also read a report that indicated, so we've already pointed to the ways in which race was involved here, in which poverty was involved, but also apparently illiteracy was involved. And at least one or two of the people involved indicated that the illiteracy of the subjects allowed them to continue to do what they were doing because they couldn't read the newspapers or they couldn't know what was going on in the larger world, and thus were easier to exploit. Yeah,
and the thing about it is these individuals were educated, but not in the traditional sense that we think of someone being educated. They were industrious. They were, agriculturally trained. They were making a living for their families, but they didn't have a lot of excess, right?
Right.
So the fine print, even if they were able to understand it, it wouldn't have really mattered because, they were being offered something that was pretty substantial, free food, free room and board. And another incentive, which, is not as commonly known, is they would have their burial service completely paid for by the study. So if you think about it, syphilis had been pretty much understood as a death sentence for people. You were going to die of syphilis if you got it in the 20s and 30s, because the treatment for syphilis back then was like arsenic and mercury, all these really, really toxic things that probably did as much damage to the body as syphilis did. And so, pretty much if you had syphilis, you would die with syphilis. But to offer these families, we'll pay for your funeral. That was like a big deal.
Yeah.
You can now have a nice funeral for your loved one. And so that was a very, very attractive incentive for these families as well. They would have a free funeral. And you think about the kinds of funerals that they were able to have without this resource. It wasn't the kind of funeral that's very, dignified.
Yeah.
And so to say that, we'll pay for it. We get to really bury our loved one now with, even to some degree, with dignity and respect that they didn't even get when they were alive. So that was a huge incentive.
And I think part of that so-called incentive then allowed the government to have control over autopsies of the bodies after death. Yeah.
They had control over everything. And that was where they got a lot of their data. And so here's the thing with human subjects research that gets you, right? Something is not ethical or unethical because of the information you get. It's either ethical or unethical when you start the study. And even though we learned a lot about syphilis during this time, how we got the information is completely unethical. If you think about the Willowbrook Hospital in New York, right? These mentally disabled kids, they injected hepatitis into them. But Lee, that was the study that gave us all the information that we know about hepatitis. It was that study that gave us the two main strains, hepatitis A, hepatitis B. We learned it from unethically treating mentally disabled children. That's how we got the information about hepatitis. So you think about that. You think about what we do in ethics and Christian education. The ends, in this case, never justified the means.
Yeah. And we have this sort of stuff going on precisely at the time the Nazis are doing some of the most horrific sorts of examples of this.
Oh, yeah.
And I guess it's yet another episode or episodes in American history where it's much harder to look at your own government, perhaps, and acknowledge, this sort of grave injustice and deception is occurring, because we don't want any sort of moral equivalency with the sorts of experimentations that the Nazis might have been doing.
Yeah, well, and it's interesting that you say that, because during the time of the concentration camp experiments, we were doing experiments on our own citizens here.
Yeah.
The Manhattan Project. We exposed thousands of people to radiation because we knew that nuclear warfare was going to be the thing during World War II. So we did radiation experiments. We did radiation experiments on kids. All of the things that we indicted this so-called depraved regime of Nazis, everything we indicted them for in the United States, we were doing to our own citizens.
Yeah, in terms of the medical experimentation.
In terms of medical experimentation, we were doing the exact. But here's the thing: when the Nazi physicians were during the doctor's trial, right, Nuremberg, they said that we were doing this to protect our military, and we said, no, you can't do that to protect your military. But when we were questioned here, while we were doing that to our citizens, guess what our response was? It was to protect our military. Right? So it's okay for us to do it to protect our military, but Germany, they can't do it to protect their military.
Yeah.
And then this whole thing about the nuclear warfare, who was the only country that actually dropped a nuclear bomb?
Yes.
So everything that we were trying to keep them from doing, we ended up doing.
Yeah.
So that's probably another show.
It is another show. It is another show, but I'm flashing back to one time when I was working on a particular book, and I was sitting in a office of a dean at a university in Istanbul with a number of Muslim scholars from different disciplines, and we were talking about rules of war. And at one point, we were talking about weapons of mass destruction, and one of the Muslim scholars bristled, and he said, "Look, we know the only country that's ever dropped an atom bomb on civilian populations." And again, a sobering sort of moment. Yeah.
And another study I just want to remind you of, and you probably know about this as well. So also during this time, there was a malaria project here during around the same time. And what we did was we injected prisoners with malaria. It was called the Stateville Penitentiary Malaria Project.
Was that Ohio?
Ohio, yes.
Yeah.
We injected malaria into prisoners, and we said that if you allow yourself to be injected with malaria, you could actually reduce your prison time.
Oh, my Lord.
And this study went on for many years as well.
What was the time frame of that study?
So we're talking about late 30s to mid 40s, around the same time that the syphilis study and the same time of the concentration camp. So, you had all this stuff going on. You had all these things that were going on in the United States that were going on sort of parallel with what was going on in the concentration camps in Germany. But for some reason, it was justified because of how we as a country felt about who was important and who wasn't. So it's okay to do an experiment on a prisoner. They're the dregs of society. So it's okay to do experiments on people of color because, they're not real citizens anyway. That was sort of the mindset.
Right.
Now, it was bad for Nazi Germany to do it, but for some reason, we were okay with doing it here. And tying this back to what we're talking about with social justice, right? What social justice really comes down to, who's important, who's not important. And social justice plays out based on that premise, right? So if there's a certain population that as a society we don't feel is important, then we can do things to them differently than a part of society that we think is important. And healthcare is the same way, right? So I'm going to give you an example to sort of bring this home. My wife was being seen at a hospital where I was a vice president. I was in my office. She was being seen in one of the rooms. So, I leave my office, I'm going to check on her. And so I go, and she's just sitting in a room. I said, "Has anybody come in here to see you?" "No." I was like, "Wow, you've been in here for a really long time." She's like, no one's come in and check on me, nothing. So I walk out into the hallway, and then one of the physicians sees me. He says, "Hey, Dr. Byrdsong, how are you?" I was like, "Oh yeah, I'm good. Just just working hard, blah, blah, blah." And he was like, "Was there anything I can do for you?" And I said, "No, I'm just coming here to check on my wife." And he was like, "Well, who's your wife?" So then I point to the room where my wife has just been sitting there. No one checking on her. Now, all of a sudden, all hands on deck. He goes in and check on her. He finds out what nurse is assigned to her room, blah, blah, blah. Now, why do I bring this up? Because it becomes an issue of who's important and who's not. Now, all of a sudden, my wife is important. And now I'm going to treat her because now I realize that her husband is an executive at this hospital where I work. And so why did I have to come there and make my presence known for my wife to be considered important? And so that's sort of what we're dealing with when we talk about social justice.
You're listening to Tokens, Public Theology, Human Flourishing, The Good Life. We're most grateful to have you joining us. We do love hearing from you, and I've been especially thankful to hear of late from old friends who are listening, like my former student and fine human being, Phil McLean, just east of us here over in Lebanon, Tennessee. My friend Dana Davis, listening up in South Bend, Indiana, who thought the Beth Barr episode was, as she said, absolutely fabulous. Thank you, Dana. John Wood, former neighbor in Abilene, Texas, now listening on his lunch breaks while walking the hills of Malibu, California, perched out there on the West Coast. We'd love to hear from you too. You can email us at podcast@tokenshow.com. Also, remember, you can sign up for our email list or find out how to join us for a live event, all at tokenshow.com. This is our interview with Dr. Quincy Byrdsong. Coming up, we'll hear more about the ways in which racial and social factors have maintained the gap of health inequities in recent years, as well as potential methods of education and social justice that can serve to bridge that gap. Part 2 in just a moment. Welcome back to Tokens and our interview with Dr. Quincy Byrdsong. So let's fast forward to the last year and a half.
Sure.
How do you see this history, these various historical episodes playing into what's happened with the pandemic, with populations of color in the United States, and either access or, I would assume, we also have issues of misinformation, potential distrust. All of a sudden it gets really messy by the time you get to something like a global pandemic, where then you have federal authorities saying these are the things that we need to do. What are things that have been observed and noted that have played out in the last 18 months?
Yeah, so the health inequities that I described that have their roots all the way back to slavery, the pandemic exposed them even further. So here's how it exposed them. In the hospitals, we saw the people that were being treated for COVID-19. You would look in some rooms and the entire room would be of one race ethnic group. It's like, wow. Now, there's no biological reason why a Black person or a Latino person has something genetically wrong with them where they're more likely to get COVID-19. So why is it that we saw such a disparity? Then we were able to tie in other factors. The health of those communities. What was one of the number one predictors of mortality in COVID-19?
Whether you had comorbidities, right?
Comorbidities. And then what was the second one? Obesity. So now we have to think about people of color are disproportionately more obese than not people of color. Why is that? So then you have to go back even further. Then you have to tie in things like social economics and education, right? Now, 50, 60 years ago, you could really tie in race to socioeconomic and education. But now it's harder to do that because now people of color are more educated and have more money than they've ever had. So now you can't say racial minority and underserved. Now you can't say those in the same breath in the same way you could 50 or 60 years ago. If you were a person of color, you probably were not educated and you probably did not have. But you can't say that now. And if you were to say that now, that would be a very racist thing to say.
Right. Yeah.
So for me to say, okay, I'm educated and I have means, and for someone to say, well, you don't represent Black people. I mean, Lee, how racist is that?
Right.
Because I'm educated and have money, I can't represent Black people. I mean, just think about how racist of a statement that would be. But at any rate, so when you tie all this stuff in together, all of this came out during COVID-19. We saw disproportionate, cases, disproportionate hospitalization, disproportionate mortality. And then when the vaccines happened, we saw a different health inequity, didn't we? We saw a health inequity as it related to socioeconomic class. So the highest predictor of who got the vaccine during the first 3 months of the vaccine was not race. It was socioeconomic status. Mm. If you had money,
you got it.
You got it. And what we saw is there was this priority that the states developed that no state followed. So the priority was, frontline healthcare workers, elderly. That was a priority, but that's not who got it. The people who got it were people that had connections, people that had money. So whereas you had hospitals who didn't vaccinate their frontline workers first, they vaccinated their C-suite first, their CEO, their CFO, their development officer. That's who got vaccinated first. And then they vaccinated their frontline workers. But they did it under the auspices of, well, we want to set the example.
Yeah.
But I mean, you don't have to do that to set the example.
Yeah.
Get the vaccine to the people that are more exposed. I mean, you were vaccinating people that hadn't been in the office in months. You were vaccinating people that did not have to ever expose themselves. Frontline workers, they didn't have that luxury.
I was surprised about how I would overhear conversations where I realized if I chose to go out here and jump the line, I have access. I could do that. And it was important for me to wait my turn, which I did.
Yeah.
But it was really surprising to me to see how many opportunities there would have been for me to jump line, because I'm reasonably connected in this town. And so, yeah, it was fascinating to see how
and that
worked.
Was the reason why, I mean, I did the same thing, Lee. I didn't jump line and, you can go over here and get, I'm like, so it's not my turn. If I get vaccinated, then I'm taking the vaccine out of the arm of somebody else. I said, it's not my turn. I said, when it's my turn, I'll go. But, no, I can't. I'm not going to go just because I know, such and such over at such and such. And, Lee, you think, but I'm the vice provost of health affairs for a university. I mean, I could have gotten the vaccine and I could have been the very first group of people that got it.
Yeah.
But I was like, that's not right. It's not my turn. I'm not a frontline healthcare worker. I can work from home. I can do what I do from home.
Yeah.
I don't have to expose myself to COVID. Now, these frontline workers, the people that clean our buildings,
right?
They can't. They don't have that luxury. You can't be a custodial worker and work from home.
Yeah.
So I want them to get it because they don't have the luxury that I have of being able to work from home if I need to.
Yeah.
So
what are some of the other things that have been exposed over the last 18 months or so?
So, yeah, we've been exposed, Lee, in two ways. We've been exposed in a good way. So let me tell you the good ways we've been exposed. Our ability to develop a vaccine this quickly.
You're right. It is amazing. It's astonishing.
Unprecedented. There's never been a vaccine developed this quickly in the history of the world. So we're exposed in the sense of, gosh, if we need to, we can put together a vaccine that'll at least reduce the spread of a pandemic pretty quickly. So we were exposed there. We were exposed to how well our emergency preparedness was, it's particularly in this state. I mean, we were able to just go right into gear, sort of mobilize the troops, if you will. I mean, we were able to do that. I mean, and we had no idea, I think, how well we were prepared for a pandemic. So those are some of the good ways we were also exposed on how good our technology is. All the things that we were able to do, not just with the vaccine development, but how we were able to use other types of medical procedures, how we were able to be creative with ventilation machines, ECMOs, other types of medical procedures, and we just sort of put them into place, air filtration technology, all this kind of stuff. Where we were exposed in the bad way is, number one, sort of the health inequities. That was the big thing we were exposed. We were also exposed in how hard it is to make people do things. A la the mask. We thought that we would just say, hey, you got to wear a mask. It didn't work like that. And people that didn't want to wear a mask were very adamant about not wearing the mask. And there was really nothing that we could do to really enforce that mandate. We had mandates and said you would get fined and all that kind of stuff, but it was very, very inconsistently enforced. So we were exposed there. And then we were exposed, back to the health inequity thing, we were exposed a lot about who we thought were important and who we thought were not important. Because we saw so many differences in who got treatment, who got the vaccine. It was like, wow, we've come really, really far. There's still an issue in this country of who's considered important and who's not.
So you've been doing this kind of work for decades now. And so a personal question, if I may.
Absolutely.
How do you, as an African-American man dealing with these issues, how do you navigate what I would speculate are sort of natural human emotions of anger, potentially resentment or bitterness, in realizing wave of injustice? What's that been like for you?
It's been really, really challenging for me, particularly in my career. Professionally, it's been challenging. I still realize that my industry is not really comfortable with people that look like me in positions that I'm in. And there's a comfort level. The comfort level is attached to racism. Let me give you what my definition of racism so you can, operational definition for our talk, right? Racism is the mentality. It's the feeling that everyone in a race has similar characteristics, and these similar characteristics determine what race is superior to another. So that's how I define racism. So it's what you think about people, not necessarily what you do, because you can be a racist without doing racist things. Okay?
So a presumption of a sort of supremacy of some sort of one group over the other.
That's it. That, to me, that's what racism is. So kind of connect that to me, people not being comfortable with me. They're not comfortable with me in these positions because of the racist ideology that the race that I represent, the black race, is inferior to the white race, which by default means that I can't be in a position like I'm in now because my race is inferior, not Quincy Byrdsong.
Right.
But the race I represent is inferior. Yeah. So there's a comfort level there, and I have to deal with it. So what ends up happening is I have to be better to be looked at as equal. And this is something my dad taught me when I was really, really young. You know, he used to tell me, Quincy, it's not just enough for you to perform at the same level. You have to perform at a better level to be considered even on the same level because of the notion that I start out inferior. So two of us are there. You're superior, I'm inferior. So we're starting out there. So I have to get from the starting position of inferior to something, closer to what society would think of as where you are, even for the competition to start. In order for me to beat you in the competition, I can't be where you are. I had to actually be better because I've already had to start out from a position of inferiority to begin with. Not that I actually am inferior,
right,
but I'm perceived as such. So yeah, it's been a challenge.
So this was something that your father was explicit with you about as a young man.
Explicit with me. Well, he went through the same challenges. I mean, he was not able to teach. He was a college professor. He wasn't able to teach at predominantly white institutions. During that time, black people in the academy, they were really restricted to teaching historically black colleges and universities. My dad didn't have the same opportunities I've had. I've worked at Vanderbilt and VCU and now at Lipscomb. So, back in his day, he would have never had those opportunities. There are opportunities that we have now that, I don't take lightly because I know that people before me, I stand on their shoulders. I don't think that a lot of people that get these opportunities understand what people were denied from me. My dad, Lee, lived in a city, a county that the high school in the county didn't even let black students attend. So he was raised in a society that was designed for him to be a permanent underclass. 8th grade education was the best he could do. So.
And then to go on and be a college professor.
Well, he didn't accept that as his reality. He said, there's got to be a high school somewhere.
Right.
That lets black people go. And so he went to a different county, got up at the crack of dawn and got on a bus and or
Wow.
train or whatever it was. Went to this other county that allowed black people to go.
Huh.
He ended up being the first person in his city to graduate from high school. So we're not talking about first generation college.
Wow.
We're talking about first generation high school. But he said, that's not going to be my reality. This society is set up for me to be a permanent underclass, but I don't receive that.
Yeah.
And so he goes there, and then he ends up going to Fisk University right here in Nashville, Tennessee. Becomes a college professor, had a 40-something, career.
Wow.
In the academy. And
what was his discipline?
English. And retired as a very, very well-respected academician. And all those things, but he did it in spite of what was stacked against him. And so
he certainly was speaking out of his own experience when he's giving you this advice.
Lee, he was saying, Quincy, you don't have any excuse.
Yeah.
I mean, he said, look at what I had to go through just to get anything. And so he didn't really leave a lot of room for me to make excuses for not being everything that I could be. So, but you asked the question about the anger. I do need to talk about that. So it's frustrating, but it doesn't anger me because anger is what society expects to be my response. If I respond to things in an angry way, I'm actually feeding into sort of the narrative about what my race represents. So to me, the proof is in what I do. So I perform. And I let that do the talking. Everything that I do, I'll do my best to be not just excellent, but elite. And the predictive index, whatever it's called, strength finders. So I'm a maximizer. So one of the things that I do is if something's good, I want it to be great. If it's great, I want it to be excellent. If it's excellent, I want it to be elite. If I take on a project and I don't think I can make it elite, I'll say, well, I'll probably need to move to the next project. And so, but yeah, I do my talking that way. I don't express it with anger. In my entire career, I've never pulled the race card, ever. Ever. And if a door's closing on me because of race, I don't get angry. I just know that that's God's way of telling me that there's another door for me to go. And I'm going to be where God calls me to be. And that's going to be enough. It's played out for me well throughout my career, by the grace of God. But yeah, it's frustrating more than making me angry. If I respond in that way, then all people will see is the anger, and they don't really see what else I bring to the table. So I don't really, if I'm going to be angry, I could be angry in my own little personal, my own little personal way of processing, what's going on around me. But it's a lot out there, Lee. But I got to say this, I'm very blessed and fortunate in spite of what's going on. And I do my best to let Black males that are younger than me, make sure that I encourage them. And I make sure that they see me. They need to see me and what I'm able to accomplish. And they need to know that they're not a thug. They're not a thug. They're not a criminal. They're not a slacker. They're a king. And that's what I tell them. And that's what they need to hear. And then also my young white males need to see me too. And I know that's not something that you hear a lot. The young white males need to see me just as much as the young Black males. Because
that makes lots of sense to me.
Because, because the media has created only 2 Black males the media shares with you. And they're at the 2 extremes. All right, so the media has shared with us the lower extreme, the thug, the criminal, the shiftless, the lazy. Media gives you a lot of examples of that. Most of the time when you see a Black male on the news is because they've committed a crime. So they're framing that. But then there's other extreme. There's the exceptional. There's the Oprah Winfrey, Barack Obama, LeBron James. So the media gives you either one or 2 extremes. So when you see me, Lee, you have to decide which extreme is Quincy Byrdsong. Unfortunately, some of our young Black males get tagged with the other extreme, the criminal thug, the lazy shiftless. Very seldom are they seen defaultly as the Barack Obama LeBron, right? Unless they're excelling in some sort of sport or something like that. But if just, first glance, it's like, okay, which one? Which one are they? So that's why, the young white males need to see me. And I don't know what category that they would defaultly put me in, but they need to see me like, hey, this is a Black male that has carved out his place in the world. He's passionate about what he does. He loves what he does. He's good at what he does. They need to see me just as much as the Black males because they need to know that there's not just 2 Black men that exist, the criminal or the president of the United States. There are Black people that are achieving in many, many ways. My brother is a judge in the largest court in Los Angeles. And we're not freak accidents, right? We had a dad that was telling us that we were a king, but we had a society that was telling us that we were a criminal. So it came down to who do I want to listen to? Do I want to listen to the people that are telling me that I'm a king, that I can be anything I want to be? Or do I want to listen to society telling me that you're destined to be a criminal? You're destined to be dead by the time you're 21. So it just comes down to a matter of who we're willing to listen to. And then we become a product of our expectations. So you can go to my neighborhood and then you can see me, you can see my brother as a judge, you can see bank presidents. This is in my community I grew up in. But then you also see the people that are in jail right now. You see the people that were killed in criminal activity. So you see both. So this notion of, your environment dictates, that's ridiculous. How could two sets of people in the same neighborhood have such drastically different outcomes? Can't be the environment. We grew up in the same environment. These people I'm telling you about, they're in jail right now. We used to play football in the front yard together. Our family situation was similar. These are 2-parent households. I had a 2-parent. But there were some people that said, hey, I'm buying into what society thinks I am, and they went down that path. I decided to go down the path of, hey, I can be anything that I want to be. And so the more that our younger generation sees that there are paths that you can take in spite of sort of the things that are going on with injustice, you can still do things in spite of that. So
we've been having a delightful conversation with Dr. Quincy Byrdsong, newly here colleague of mine at Lipscomb University, Vice Provost for Health Affairs here in Nashville. Thanks so much for the wonderful conversation.
Oh, thank you, Lee, for having me.
Great to have you as a colleague now.
Yes, been a good time. Thanks.
You've been listening to Tokens, Public Theology, Human Flourishing, The Good Life. Remember, you can subscribe to our podcast on Apple Podcasts, Spotify, Stitcher, or wherever you get your favorite podcasts. If you'd like to hear more on the topic of America's history of racial inequality, then check out our Season 3 episode entitled Fear, Home, and the Asian American Experience. If you'd like to hear more about the history of racism as a sociological and theological construct, we encourage you to check out our interview with Professor Willie James Jennings of Yale University. If you got feedback, we'd love to hear from you. Email us, text, or attach a voice memo and send to the address podcast@tokenshow.com. Thanks to all the stellar team that makes this podcast possible. A most outstanding team, really. Executive producer and manager Christy Bragg of Bragg Management. Co-producer Jacob Lewis of Great Feeling Studios. Associate producers Ashley Bain, Leslie Thompson, Tom Anderson, and Brad Perry. Our engineer Carriot Harmon. Music beds by Zach and Maggie White and Blue Dot Sessions. And our live event production team at Stonebrook Media, led by Phil Barnett. Thanks for listening, and peace be unto thee. Tokens Podcast is a production of Tokens Media LLC and
Great Feeling Studios.